Welcome to the Patient and Family-Centered IPASS Training Core Content Module. This is the start of your training in Patient and Family-Centered IPASS, PFC IPASS. This training will prepare you to communicate more effectively, increase family engagement, and develop a shared mental model when you conduct family-centered rounds. This training will consist of some pre-work, including this video module to be done independently, an in-person training session, and then ongoing rounds observations and feedback as your team implements PFC IPASS. Our learning objectives for the training overall are to enable you to activate and engage families and all members of the interprofessional team to create a shared mental model, apply health literacy principles to improve communication, to discuss the roles and responsibilities for various team members during patient and family-centered rounds, incorporate IPASS structured communication as an organizing framework for patient and family-centered rounds, PFCR. Demonstrate effective use of written information to facilitate communication with families and the interprofessional team, and list appropriate educational activities for patient and family-centered rounds. This pre-work core content module will be focusing on health literacy and the IPASS framework. The current state of family-centered rounds is really better called family proximate rounds, with excessive medical jargon, a lack of substantive family engagement or attempts to ensure family understanding, as well as a lack of substantive nurse engagement. Pilot data from Boston Children's Hospital shows a 45% discordance rate for understanding the plan of care between families and the medical team. Why is it important to rethink how we conduct family-centered rounds? Let's hear why this is important from a family member's perspective.
Hi, I'm Miranda Ashland.
And I'm Michelle, her mom.
And we think that having rounds is very important, and including the patient is extremely important. They are the ones who know their bodies the best and know how they are feeling the best and can speak to that to the doctors who are ultimately there to provide them the best care that can be given to them.
Can you tell Miranda had a liver transplant when she was a tiny baby? This is she and I right after her transplant when she got out of the hospital. So she's had a long life. First, I helped form partnerships with the providers as she grew up, and now she does that for herself.
Yeah. Recently, I was in the hospital for the first time in like many years. I'd never been in the hospital when I was an adult and could speak for myself, and so I really definitely learned the value of speaking up, speaking to my doctors, making sure I knew what they were talking about, I knew what the plan was before they left the room and they were gone for the day, and so I really think that's very important to include the patients. Thank you.
The results of activated and engaged families are clear. These benefits are supported by the pediatric literature. Sitting around a hospital room all day feeling exhausted and helpless is very difficult. Engaging the family as an important team member and focusing on family-centeredness can allow families to feel that they are part of the team that is working to heal their child. It helps with, for families, knowledge of the team members' roles, consistency of relayed medical information, the ability to participate in decision-making, an understanding of the plan, and perceptions that doctors are listening and are respectful. For patient care, it's less total time rounding per patient, but more time with patients and families, less wasted time and duplicate conversation, earlier discharges, and less time to complete key studies. To further explore the impact of a standardized approach to family-centered rounds, the Patient and Family-Centered IPASS study was born. This was a multi-center study across 7 inpatient pediatric units looking at implementation of a multifaceted structured communication intervention for family-centered rounds. The program consisted of 3 core intervention elements: structured verbal communication on rounds, structured written communication on rounds, and utilization of communication, teamwork, and health literacy best practices. There were Different key supporting activities, education and training activities, implementation and sustainment activities to facilitate this intervention. The overall goal of all of these components is to facilitate a shared mental model between healthcare providers and families. This study evaluated as primary outcomes medical errors, including both harmful errors, preventable adverse events, and non-harmful errors. As secondary outcomes, we evaluated the family experience and the rounds process. Patient and family-centered IPAS study findings showed a 38% reduction in harmful medical errors with improvements in the family experience and hospital communication processes, but no change in the length of rounds. This has been published in the British Medical Journal. During the phases of your PFC IPAS training, you will learn certain key provider actions that promote improved communication and activation and engagement of our families to promote true family-centeredness. We are now going to cover the first action, utilizing principles of health literacy in this module. We will practice the health literacy skills that you learn here in the in-person portion of the training. Health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. It includes the ability to access and navigate the healthcare system. It is critical to keep in mind that health literacy is a state, not a trait. This means that a person's baseline health literacy can change over time and depends not just on the person's baseline health literacy, but on stress levels and cognitive load. So even someone who is a healthcare professional, such as you or I, in a moment of stress when dealing with a loved one's illness may have a lower level of health literacy than at their baseline. Health literacy is a large problem. About 30% of U.S. parents have the lowest health literacy levels, but what is even more notable is that only 15% of U.S. parents have proficient levels of health literacy, meaning that the vast majority face health literacy challenges. Numerous studies have linked low health literacy to poor health outcomes. In adults, low health literacy is associated with higher hospitalization rates, greater use of emergency care, incorrect medication use, such as difficulty interpreting medication labels leading to medication errors, and lower use of preventive health services like mammography screening and getting the influenza vaccine. There's greater difficulty in understanding health messages and worse overall health status and higher mortality rates. In the pediatric context, poor health literacy among parents is associated with worse child health-related knowledge, worse behaviors, including incorrect medication use and worse disease management, and worse child health outcomes, including for children with asthma and diabetes, such as more ED utilization and more hospitalizations for children with asthma. Poor health literacy is considered one of the factors that leads to income and racial and ethnic and socioeconomic disparities in health outcomes. Think of these health literacy pearls as universal precautions. They should be part of every patient encounter. Speak clearly and not too quickly to give families and the team time to process. Use plain living room language. Think about the language you might use with a grandparent or friend. For example, say use instead of utilize, or give instead of administer a medication. Avoid medical jargon and medical terms. For example, think every 4 hours rather than Q4. Fever rather than febrile, eating and drinking rather than PO, through the IV rather than intravenously. Check for understanding using TeachBack. Try not to make it feel like a test. Put the onus on yourself. For example, I want to make sure I did a good job of explaining things to you. Can you tell me the main things we need to do in the hospital before we decide that Mikey is ready to go home? And last, organize things into 2 to 3 concepts to discuss at a time. Think chunk and check. Really focus on emphasizing the important action steps and behaviors. Break information into digestible, bite-sized pieces and focus on the need to know rather than the nice to know. Universal precautions for communication. Use them every time. Physicians need to be able to speak fluently over a communication spectrum. With other members of the healthcare team, they need to be able to use medically rich language which is precise with highly synthesized concepts. Medical shorthand is used in this communication. The other end of that spectrum is with patients and families, using living room language with simple, clear sentences, organizing communication to focus on 2 to 3 key points so as not to overwhelm families, embracing the pearls of health literacy and using these pearls as universal precautions. We will now transition to cover the IPAS structure for presentations. The IPAS mnemonic serves as an organizing framework for rounds. We will discuss the elements here and then you will practice them during the in-person training. Let's start with illness severity and introductions. All families should have the option of participating in family-centered rounds. Older children may choose to participate as well. Parents have a unique perspective as members of the care team. They know their children better than anyone else and have an insider's knowledge of what techniques and therapies may or may not work for their child, what cultural considerations will come into play, and what barriers exist. Families are the expert on their child. After assessing whether a family would like to participate in FCR today, determine their preferred location, inside the room, at the doorway, or outside in the hall. Have team members, including parents and patient, introduce themselves and their role. Consider having the family introduce themselves first to reinforce their role as part of the team. Review the concept of FCR as a time for the entire medical team to discuss a child's care so that everyone is on the same page and for the family to be informed and involved in decision-making. Review the anticipated time allotment, letting the family know that you will spend the next X minutes discussing their child's care and that team member Y is happy to return at Z time to discuss any remaining questions and provide clarification. Let families know you value their input and you encourage them to speak up and let the team know if you don't get something right, if they have something to add, or if they have questions. Treat them as the expert. The next step is to engage the patient and family by eliciting their concerns. A patient's or family's concerns may not be the same as the chief complaint. A family may be worried about a fever causing harm to their baby, for example, when you are more worried about what is causing the fever. Addressing both will be important. In addition, while you may be worried about the cellulitis, the family's primary concern may be missing work. Articulating concerns in the beginning guides the development of a shared mental model. Important things may come out that cause you to alter your proposed plan. It is important to acknowledge the concerns and let the family know you will be talking about these concerns in the problem-based discussion. You may address these concerns earlier in the patient summary, or if these are concerns that cannot be addressed in the moment, make sure to let the family know you will return. Make sure that your nonverbal communication encourages sharing. This may be an opportunity to check for concerns of other team members as well. All of this promotes development of a shared mental model. If the parent agrees with the medical team's illness severity and their concerns are similar, then rounds can continue with everyone on the same page. If the parent's illness severity and the medical team's illness severity do not agree, or if their concerns are disparate, then there must be more discussion before rounds can move forward. You can say something like, "Tell me more about why you think Johnny is doing worse." There may have been an interval event that the team is not aware of, or the parent may have concerns. A discordant understanding offers an opportunity for explanation or revision of the plan. Once you have come to agreement or have agreed to disagree for the time being, you can proceed with your rounds discussion. The next element of the IPAS mnemonic is P for patient summary. This is your integrated assessment and plan for each of the issues facing your patient. The purpose of the IPAS FCR framework is to center the rounds discussion to focus on the patient and family. The patient summary in particular is a critical opportunity to move beyond a passive update, but to engage the patient and family in shared decision-making and promote a shared mental model between the family and medical team. The presentation, therefore, focuses on the patient and family, using language that they understand, and avoiding data overload from just reciting numbers regardless of relevance to family. The exact order in which information is relayed and the amount of detail discussed is flexible, as long as the ultimate result is a shared mental model between the patient, family, and the medical team. The discussion should evolve as the patient's status changes. Problems change over time, so what was a fever yesterday is now a pneumonia today. Some problems become diagnoses, and this is expected. Also, some problems go away, and it is okay to mention this and then not talk about it in days to come. Techniques such as checkback ensure that patients and families are active participants in the conversation. While teachback generally occurs after situation awareness and contingency planning, it may be helpful after a detailed patient summary, especially for complex patients. All of this allows a transition from patient and family present rounds to patient and family centered rounds. Ideally, the patient summary is a problem-based discussion with the patient and the family. Families do not think of their children as overnight events, vital signs, and physical exams. They are concerned about their children's symptoms and medical problems such as fever, dehydration, and difficulty breathing. By focusing on the problems, including an assessment for each problem with pertinent positives and negatives, one can also better focus on clinical reasoning. Attendings and senior residents can better determine why an early learner came up with the diagnosis and/or the plan for each problem. It creates a tighter link between the findings and the problem. For a problem-based discussion, the conversation starts with a one-liner and global assessment so that the entire team is oriented to the patient and his or her big picture. The one-liner and global assessment should include key identifiers, pertinent past medical history, events leading up to diagnosis, the working diagnosis or differential, the patient's trajectory, and a list of active issues for which the patient remains hospitalized. This should all be relayed in patient and family-friendly language. Each of the patient's issues or problems is then discussed in order of priority. By incorporating evidence and data from overnight events, applicable vital signs, physical exam findings, and the results of labs and imaging studies into his or her assessment and plan, the presenter demonstrates his or her clinical reasoning to colleagues and families alike. This evidence and data can be thought of as pertinent positives and negatives. The format can be ordered as is most comfortable at your institution, whether the SOAP format with subjective data, objective data, and assessment and plan, or ASOP with an assessment, the subjective and objective data, and the plan. But regardless of which format is used, the presenter must be mindful to use plain language and avoid data dump, such as the recitation of all vital signs and ins and outs regardless of their significance. The amount of detail should depend on the needs and preferences of the family. Discharge goals should be discussed at this time as well. Let's look at a sample of a portion of a patient summary to see this format.
Thanks, Debbie. Again, as an overview, Claire is a 13-year-old girl with sickle cell disease who was admitted yesterday with a pain crisis, but overnight began to develop respiratory distress. She's had acute chest a few times in the past, and we believe that's what's happening this time too. Her breathing has been a little faster this morning, in the 30s and a little harder, and her oxygen level has dipped from the 90s yesterday down to the high 80s this morning, so she was started on 2 liters of oxygen through her nose. When I examined her this morning, I saw that she was not moving air as well, and I heard sounds that we call crackles in the lower parts of her lungs, especially on the right side. Crackles mean that there's fluid in the air sacs of the lungs, which can happen with acute chest. In addition to the oxygen, she's been on fluids through her IV to treat the acute chest and on 2 different antibiotics, ceftriaxone and azithromycin. We're not sure that Claire has a bacterial infection in her lungs, but with acute chest, we normally are very careful and start treatment right away. That's why she's on the 2 antibiotics. What questions do you have about that?
Not so far.
The next element of the IPAS mnemonic is A for action list. The action list is the to-do list for the patient. It is a summary of what specific actions will be taken. For example, orders, consults, studies, procedures. The items should include a timeline for the tasks. The majority will focus on items for the day, although if pertinent, a future task may be mentioned as well. Ownership and follow-up plans are critical for the action list. For example, who will update with the family with the urine culture results, and when can the family expect this update? Remember to use patient and family-friendly language when you discuss your action list. There may be terms or abbreviations that you will need to explain so that all members of the team, including the family, understand the next steps. Consider that when feasible, if tasks can be efficiently completed on rounds, they should. With computers on wheels, for example, the intern who is not presenting can be charged with entering orders, or they may be able to call a consultant. The next element of the IPASS mnemonic is S for situation awareness and contingency planning. Situation monitoring is the act of assessing a clinical situation through active scanning of behaviors and actions. An example of situation monitoring is when you pre-round in the morning. We talked earlier about how important it is to review your patient's vital signs, get thorough handoff from the overnight team, and read new notes. The act of situation monitoring results in individual situation awareness. As you synthesize information on pre-rounds, you develop situation awareness. Although individual team members may possess situation awareness, it is only when this awareness is shared through communication with other team members that a shared mental model is attained. When you have situation awareness, you can use that awareness to draft practical contingency plans. Contingency planning includes thinking of what may happen and problem solving before things go wrong. It involves thinking about if this happens, then we will do. In the context of daily rounds, it's discussing things that the team, including the patient's family, physicians, and nursing staff, should be watching for throughout the day and drafting an action plan. While it may be a physician provider leading this discussion, nurses should be encouraged to ask questions as the primary medical caregiver at the bedside. Contingency planning is critical in order for the team to anticipate changes in patient status and respond appropriately. The final element of the IPASS mnemonic is S for synthesis by receiver. Synthesis by receiver is crucial to a shared mental model, whether in handoff, during rounds, or even as you order food at a restaurant. It involves a brief synthesis of essential information. Having the receiver restate the essential information demonstrates that the information has been received and understood. It's also an opportunity for the receiver to ask any clarifying questions he or she may have and to have an active role on rounds. It helps promote a shared mental model. Synthesis by receiver is also called teachback. In our IPASS format of family-centered rounds, we encourage the family to do teachback, sharing their understanding of the care plan with key takeaways, plans for discharge, etc. Nurses should be asked if they agree with the plan. How do you ask a parent to synthesize? Synthesis by receiver is critical to a shared mental model, but asking a parent to synthesize the information provided on rounds is different than asking a nurse to read back a verbal order or an intern asking his or her colleague to summarize the to-do list at handoff. It requires asking open-ended questions in a safe environment and placing the onus for good communication on the medical team. Closed-ended questions such as "do you understand" or "do you have any questions" are ineffective. The team should also avoid language that makes it feel like a test, such as asking a parent to repeat or summarize. The team should monitor for nonverbal cues that the parent doesn't understand or is uncomfortable. It can be helpful if the patient's nurse or resident has given the parents a heads up that they will be asked to synthesize or teach back their child's plan as a way of auditing how well the medical team is communicating. Rather than, "Mrs. Jones, please provide a summary of what we just discussed about Johnny's problems and the plan," consider, "We want to double check ourselves and make sure we have done a good job explaining what is going on with Johnny. We want to make sure that we are thinking about things in the same way and that we have addressed your main concerns. Can you share with us what your understanding is of why Johnny is here and what the plan is for today?" You should offer to families that you can come back to discuss one-on-one if that would make them more comfortable. Let's see what the IPASS format looks like on rounds.
He's very fluid. Oh, come in.
Good morning, Claire. Good morning, Mrs. Williams.
Hi.
I'm here for morning rounds, and I'd like to introduce our team before we start rounds. Is that okay with you?
Sure. A lot of you.
Great. And Claire, I hope you feel comfortable participating with us on rounds too. Just to start, my name is Dr. Bonowitz, and I'm going to be the main doctor. So how do you feel today, Claire?
I feel okay, but can my mom tell you?
I think her leg pain is better. So I guess she's doing better.
When we were talking earlier, Mrs. Williams, you mentioned that you were concerned about her breathing. Do you feel okay sharing that with the team?
Yes, thank you for reminding me, Debbie. I do think her breathing is a little bit harder today. Like she's just working harder to breathe. Claire, you got to tell the doctors how you're feeling, or else they can't help you.
Yeah, so Claire, are you feeling better, worse, or the same than you were yesterday?
I guess worse. I have this thing, it's been helping for my pain, but I agree with my mom, I'm not breathing right.
Claire, thank you for sharing that. We're also worried about your breathing. Let us talk together about how we can address Claire's breathing trouble. Any other concerns, Mrs. Williams?
So just to update on the overnight events, Claire was breathing harder during the night, and her oxygen levels dropped as well from the 90s to the 80s, and she was started on 2 liters of oxygen by the night team. Her leg pain does seem better.
Thanks, Debbie. Again, as an overview, Claire is a 13-year-old girl with sickle cell disease who was admitted yesterday with a pain crisis, but overnight began to develop respiratory distress. She's had acute chest a few times in the past, and we believe that's what's happening this time too. Her breathing has been a little faster this morning in the 30s and a little harder, and her oxygen level has dipped from the 90s yesterday down to the high 80s this morning. So today, we will plan to do a few things to help with the breathing and her leg pain. We will watch Claire's breathing carefully and ask her to keep doing the incentive spirometry every half hour. This little machine right there that helps make sure you're taking deep breaths, Claire. We'll also continue the 2 antibiotics, and we'll get a chest x-ray to look at her lungs. Mrs. Williams, I'll follow up with you to make sure you get the results after it's done. Debbie, can you call radiology and then find me afterwards so I can look at the results?
Of course.
For situation awareness, if Claire's breathing gets worse or her oxygen drops lower, we'll have to call our rapid response team. They're the team in the hospital who help us look at patients who may be getting a little sicker and help us decide if patients should be moved to another part of the hospital where we can watch them more closely. She may not need just oxygen, but she might need more flow to help keep her lungs open, and we call that flow CPAP. If Claire seems tired to you or is not able to speak, be ready in case things do get worse. Now we just want to double check and make sure that we've done a good job explaining what is going on with Claire. What's your understanding of the day? But Claire, if you would feel more comfortable talking one-on-one about this, we can do that too. I can come back without the whole team.
Well,
Sure. I'm used to speaking to the team. Okay, so you're saying that Claire has acute chest syndrome again, and she's still breathing fast from this morning, but we're taking a chest x-ray, and you're going to tell me the results. She can still drink stuff, but she can't eat anything, and that we all agree that her pain is better. Thank you.
And also, if anything comes up later, please don't forget to jot it down on the rounds report. These are the key things and action plan items for the day that we discussed, and we'll be back throughout the day to check on you.
Okay, all right, great. All right, thanks everybody.
I'll come back with those chest x-ray results.
So this module has introduced you to the right side of the slide, the IPAS framework. During the in-person training, we will discuss the roles on rounds and how the two integrate into the patient and family-centered IPAS rounds process. Thanks for your attention.